Thank you.
Thank you so much. Ladies and gentlemen, now we are all ready to listen to the great talk by Dr. Sanjeev. He is an inspiration to millions. He has formidable expertise in practically every conceivable aspect of healthcare. I welcome our honored Dr. Raman Sardana, Secretary, Hospital Infection Society of India, to please do the honors. Dr. Raman, please.
Thank you, Dr. Mayer. It is indeed a great honor to introduce a personality like Dr. Sanjeev Singh, who's been a great friend, in fact. And you know, sometimes one tends to feel so funny in front of his whatever he has achieved, especially while working at the helm of affairs in Kochi. So Dr. Sanjeev is a well-known figure in India and abroad. So I won't go in much details. So after doing his post-graduation in pediatrics and masters in hospital management and a PhD in infectious diseases, he worked as a regional coordinator with WHO. And then subsequently, how we know him more is his role as Chief of Medical Services at Amrita Kochi, which is a 1350-bedded university teaching hospital. He is now currently he is the medical director of Amrita Hospital, Faridabad, and designated as resident medical director. So he has got many fellowships, and as you can see, and this will not suffice, you know, to introduce him as a personality, because he's way above whatever we can write on the screen. So he's got major publications, more than 100 international and national publications with an H index of 15, and has got 14 international and national funded research projects. All-rounder, in fact, very wise person, and always somebody to look forward to meet and listen to his wisdom. So won't take much time. Dr. Sanjeev is going to talk on one of the toughest challenges we face in AMR and AMSP programs, so that is the implementation. So over to Dr. Sanjeev, please.
Thank you so much, sir. Ladies and gentlemen, please put your hands together for the dynamic Dr. Sanjeev Singh. Sir, we are thrilled to host you, and the screen is yours.
Thank you so much, Dr. Raman. The work which you do at Hospital Infection Society and in your institute is something which is phenomenal. Thank you, Dr. Meher, for organizing this. It's one of the toughest things to get all the team together across the globe, and what you have done is something which is outstanding. Getting everybody together for antibiotic stewardship, and one of the most difficult topics, UTI, because we still don't know what works, what doesn't work. And it's good to have the collaboration between Sultan Qaboos, HISI, and American Society of Microbiology. So great work, Dr. Meher, great work by you and your team, and we would like to really sort of engage with all of the stakeholders and see whether we can create any kind of a difference. So I'm going to talk about strategies, and I don't know what strategy works in which country. It's always been a trial and error. And as Dr. Livermore mentioned, pandemic was a great piece where we learned quite a bit. And then we realized that there are various pandemics which keeps coming, and they keep teaching us various lessons, and good infection control practices was one. And definitely we also realized that there were many antibiotic stewardship programs which worked, which didn't work. And that is where I think pandemics and the history of this is a great learning. What next is definitely we don't know, but the anticipation is AMR, and that is why we are all here together. There is a crisis. There is a phenomenal report which comes from Jim O'Neill, where he has written that Initial research looking only at the part of AMR shows that the continued rise in the resistance by 2050 would lead to 10 million people dying. And it's not a joke. It's going to be something, a great disaster. And every year, a reduction of 2 to 3.5% in GDP. So it's going to basically harm every nation in totality. AMR is a difficult ball game. We all realize that it is there each sector, but it is like an Indian traffic where it is however, wherever, and whenever. There has been a loss of political will, but there is a lot of work which has already been done. Governance in each institution is requires a lot of pulling up. No standardized surveillance system, though there is some kind of a network which is getting developed. The clinical engagements needs a lot of improvement. So there are multiple, and everybody knows about it. So One Health is a big topic. So we are unable to get hold of the human health, and so it is again a big ball game. And then there is no structured education and training, and that is where I think as a human health we could be a good contributor to make it happen. So resistance levels are definitely high, and you're all have been working, and the antibiotic consumptions are increasing. So, and would not spend time. Consequences are very well known, because if we don't contain this, the cost is going to be high, the morbidities, mortalities, and length of stays are going to be high. What has India done so far? Phenomenal work, though it may be just a drop in the ocean, but there has been an national containment plan. There has been a lot of states' participation. What has states done so far? Some of the states have taken lead. Kerala, MP, and Delhi have got the team together and have put in some kind of a strategic action plan for AMR containment. I can talk about Kerala because I have been very closely associated. So AMR, once you deal with it, you realize that it is a very, very big game. And whatever you do is so small. The bandwidth which you need to travel is just immense. So there are 35 medical colleges. You need to get hold of all of them, because you need to teach them or catch them young with undergraduate, postgraduates, and the prescribing pattern. If you start working with a medical college, you soon realizes that everybody needs to sort of improve. And this is where we reached out to the government of Kerala when we, within our ICUs, we realized that nothing is moving, because they already been pumped in with antibiotics. So everybody needs to improve for a comprehensive improvement. We also realized that there are these, other than the district hospitals, there are these taluk hospitals which also needs to play their own role. 99% of literacy, health-seeking behavior, primary health setup, fantastically done well since 1842, still has a lot of problems. 48 community health centers, and then close to 7,000 private hospitals, and 50,000 plus physicians. So this is the bandwidth which we need to travel. And this is where we need to strategize ourselves to be able to put everything together. And it's going to be tough, because it is just not about teaching. It is also about behavioral change and thinking about the future, which Dr. Meher, Dr. Livermore did speak about. So public-private partnership is the only way forward, because there is where we need to engage with all the stakeholders, all the societies. This is what we did in Kerala with the phenomenal support from WHO India. And we also reached out to 18 professional societies from associations of physicians, surgeons, ENT, orthopedics, dental. And then we formulated a clinical plan, a clinical guidelines, which got released. Then we formulated a AMR container, and we thought that something has been done. And nothing basically happened on the grounds. And post that, there was a 2-letter word which is extremely important in the state government, is the government order, GO. And that got released for everybody's participation, for all hospitals, for all labs, and all pharmacists. And there was a decent monitoring mechanism which also got established. So what are these strategies where people needs to sort of get together for a good antibiotic prescription practices? One is definitely having a plan, a national level plan, national action plan, which should merge with a global action plan, which is merging with the national action plan, which merge with the state action plan. And then it definitely needs to percolate down. The other strategy, which is good, is about starting smart and then focus. And this is what I feel is a good strategy, because pre-authorization many at times in an institution becomes difficult, because there is a right to prescription by each physician which gets questioned and they feel threatened. And it is good to just start smart when you have a good antibiogram by site specific, you have a good antibiotic policy, both in outpatients and in inpatient setting. And then based on that, you you promote a good prescription practices at ER, at OP, and at IP. So looking at right drug, right indication, right dose, right time, right duration for every patient, and then maybe looking back and de-escalate, stopping IV oral switches and things like that. There is again a good strategy which Institute of Healthcare Improvement suggested, that formulating a driver diagram, looking at each problem, and then formulating something which is called as primary drivers. So if there is an antibiotics utilization, what could be a primary driver? So that is a timely initiation of antibiotic, de-escalation, data monitoring, and then what could lead to the secondary drivers, and work on these change agents. So every person who sort of becomes a department or a process champion or a process owner, and work as work for this change idea, which gets implemented and monitored from time to time basis. There is also a mechanism where we could formulate a good antibiotic policy plan based on either a community acquired infections or a hospital acquired infections or a nosocomial infections, which gives a guidance note for clinicians to basically start a good empirical therapy based on the antibiograms, and then work on a more targeted therapy. And moment the samples, the report comes in, gets into a de-escalation or an escalation mode. There is a very easy mechanism also, which if we don't have the resources for a continuous monitoring, we could look at point prevalence surveillance. And point prevalence surveillance is for AMR has been very robust. Dr. Dilip Nathani and the whole group basically promoted this concept, and it comes out very handy, where you on one point of day, you look at from 8 a.m. to 8 p.m. the prescriptions which has been there in each inpatient setting and ICU setting, and that gives you a phenomenal insight to what has been prescribed, and then take an action based on that. There are other antibiotic stewardship team, which is a multidisciplinary team, which needs to be created to get a good comprehensive strategy, where everybody from the clinical team, from the governance team, from infection prevention control team, from the lab medicine team, the drugs and therapeutics, and all the support services with infection prevention also sort of participates, and then they create an environment for a rational prescriptions, and look at all unwarranted prescriptions at all points of time. There is also Dilip et al. Did present about core strategies and supplemental strategies. So this is what got adopted at the surveillance program at ICMR, where there is a formulary restrictions, pre-authorization, prospective audit, and a multidisciplinary team. At times it gets difficult with the formulary restrictions and pre-authorization, but then supplemental strategies are extremely critical, which needs to be adopted, which could be de-escalation, optimization, and antibiotic order form, looking at the justification, CDSS, and the surveillance system. And Dr. Livermore did talk about some of these cycling and combination therapy. So front-end strategy and a back-end strategy is something which works, which we have adopted, and many of the hospitals within the country, I find it extremely handy. So there is an antibiotic prescription pattern as a good strategy, and then there is a restriction based on select antibiotic dosing, which could be adopted within the institution. So it could be easy as a WHO classification of where being followed, and look at all the restricted antibiotics, be it colistin, tigecycline, alta, doripenem, and things like that. And then look at and do a prospective audit, which could be an electronic or a medical records audit, and day 1, day 4, day 7 review, and stop whenever it is required, or escalate or de-escalate. We did that, a similar exercise, and then we realized that loading dose is a problem. There are 8-9 antibiotics which require to have loading dose whenever it is prescribed. Dosing is a problem, and duration of antibiotics is a problem. So every time you prescribe this, you need to sort of again go back and talk to the team, engage with them, invest the time, so that the appropriateness of the practices are followed. There is definitely antibiotic prophylaxis is an issue, and there was a surgeon which basically always thought that giving more antibiotics helps, and he was prescribing meropenem and micapenem linezolid as a prophylaxis. And we matched the similar between 2 units of the surgical site infections, and there was another team which only prescribed, which was rational cefuroxime. And then the surgical site infections came down with the rational practices. So this particular idea of using more antibiotic, using more power to control infections is also irrational. Plus, there is a cost to the patient, and the cost of care in India is a big determinant. So can each institution play a role towards good antibiotic practices following strategies, which we just mentioned? And the answer is yes. And I could give my hospital's example. There's a multidisciplinary team which has ID fellows, which has clinical pharmacists, microbiologists, hospitalists, and they all sort of come together and take a call. There is a Donabinian model by the multidisciplinary team, which is followed, where structure, process, and outcomes are always defined. So there is everything in blue is a structure, then there is a process in green, and then look at always review the outcomes which you have sort of formulated each quarter, and always look at what are the gains for the policies which you have adopted. So appropriateness of rational prescriptions did improve. There is also vis-a-vis a decent healthcare associated infection status, which did improve. The mortality rate of infections did drop down, but then it did increase later. And there was multiple reasons, but then there is a cause of concern where we need to look back and improve. There is length of stays, and because of that, there is an opportunity to admit more and to do more cases. And so there is a significant improvement in length of stays just because of antibiotic stewardship, where rest of the parameters stays simple. There's a daily defined dose improvement with all the restricted antibiotics which did take place, but it did not also lead to a pressure effect on other antibiotics. So rationality did make a lot of sense. There is an impact which happens because of these restrictions, and there is a drop down of restricted antibiotic use. There is a cost benefit which is also important, though many a times it is said that antibiotic prescriptions does help the kitty in the hospital. But we looked at the direct cost, we looked at the indirect cost, we looked at the opportunity cost, and every year on year, there was a cost benefit, maybe a loss to the hospital because those antibiotics did not got sold, but the cost benefit was close to 2 crore, which is decent. And this is the benefit which goes to the society, where the patients did pay less. Vis-a-vis looking at infection, all healthcare associated infections. So the process of hand hygiene, isolation, wound management, looking at all the outcomes like readmissions and the length of stays and mortality, and all device related infections. So when you do both the programs together, AMR containment as well as healthcare associated infections, there is a significant drop which happens. So what we realize is your investment in just training and back to basics training of $1, the return of investment is close to $236, which is remarkable, and which is where we need to come together as a team, and the management did need to support. This is a work which we did with Imperial College, and using a tool which is called a sociogram, looking at ethnography. We shadowed the clinicians on round, and we looked at their communication pattern. And we realized that though we are a not-for-profit university teaching hospital, we did realize that the communication to the patient is limited, and most of the communication do happen with the carer. So this concept about being a patient-centric hospital is not true, at least in India. It is more of a carer-centric and a patient-centric hospital, because carer reveals and most of the information and takes care of most of the information of the patient. But the rounds are hierarchical in nature, and the communication of the senior surgeons, senior physicians on infection control and antibiotic stewardship is minimal. With our work, other than quantitative and qualitative, the rate of de-escalation was also taken care. We also looked at some of the PKPDs and of most of the restricted antibiotic. Inappropriate loading dose for colistin was a huge problem, including the participation from the nephrology team, which on a repeated engagement did improve. There is also a pattern of diagnostic stewardship, which would help in antibiotic stewardship. Sending the right kind of samples for all device related is again important, and that is again a behavioral change, which from the clinical team as well as from the nursing team, which needs to be stressed upon. Mandating the right kind of samples every time is critical. Again, a therapeutic drug monitoring mechanism, a practice which is very difficult and rare. There is a sensitization which needs to happen, especially with some of these antibiotics like vancomycin, colistins, tigecyclines, where we need to optimize the drug dosing, and which would also result in the prompt reduction in the withdrawal of the therapy. Loading dose many a times was not being practiced, so we empowered the nurse, despite the fact that the clinical team doesn't write down on the drug chart or on electronic medical records. They need to every time for the select 9 antibiotics give a loading dose, because that's the rational practice which needs to be adopted. So a lot of empowerment is important from the support staff, which needs to be also given. There are various guidelines where the clinical pharmacist developed and that got shared. There are we soon realized that we were working on antibiotic stewardship. We immediately shifted to anti-tubercular stewardship. We shifted to antifungal stewardship, because unfortunately AMR program is so big along with hospital infection control that you realize that there are so many parameters which you need to sort of take care. We started a candidemia care bundle with looking at appropriate selection of antifungals, removal of lines at appropriate time, giving an ophthal consult, and looking at their administration at as per the guidelines. And we implemented this for a Candida auris infection rates. We also realized that there is a huge kick which happens when a newer antibiotic gets introduced. And it is important also to immediately restrict that, because you never realize that it gets prescribed despite being a tertiary and a very specialized organ transplantation congenital heart surgery center. So it is appropriateness of these doses and appropriateness of beta-lactam inhibitors, anti-tubercular stewardship, antifungal stewardship is again, this is where a comprehensive stewardship program would help. And then changing the behavior by every time when you prescribe an antibiotic, writing an indication, because unfortunately we send this whole idea of writing query before each diagnosis. It makes it life very simple, and then based on that you keep sending samples, and based on that you also recommend some of the antibiotics. So changing this behavior of writing an indication every time you prescribe an antibiotic is again an important step. So what we have done right now is created more champions, and this is a huge contribution where 122 general practitioners have been trained for 14 districts in the state of Kerala. And they have been taking sessions for the rest of the general practitioners at various centers. And they take sessions on 5 modules, but these champions have huge interest, huge passion. They are knowledge, they have robust knowledge, and they work with the content. So sum up, our antibiotic stewardship program needs to be comprehensive, where public and private, all institutions needs to participate. Infection control is an important program which needs to merge with this stewardship program, and that's a big strategy. We keep talking about training, but it will not have that kind of impact until unless the behavioral change and that quantitative and qualitative nature of work needs to sort of come together. We need to create collaborative, and this is what Dr. Meher and the whole team has done along with HISI and ASM is phenomenal. And this collaboratives like this is going to have a lot of impact. Stakeholders like all of us needs to be engaged. There are lots of, what we generally do is keep following and we become a good follower. But what is important is also look at something which is out of the box and be patient and perseverance on our approach. We put in a lot of structure, and that is what we are good at, but looking at also at process and outcome would be important. And definitely standardization of work. And I would really like to thank Dr. Meher that somewhere down the line, we would standardize our work when we get all the data together. So thank you so much for this privilege, and over to you, Dr. Raman.
Thank you. I mean, amazing. I mean, that's the word which I always use. Listening to you, you have covered everything. In fact, Dr. Singh, everything. In fact, you don't leave anything for anybody to comment upon. But I would initiate the talk, the perspective on the talk. So before my other colleagues join in, just one thing which I would, and then we'll come back again, is how did you convince the physician to join and own? That is the toughest challenge one faces in implementation of AMSP in any institution. Because one can, even if one owns the hospital, and still the confrontations and the willingness is going to be terrific and may at times lead to more harm than, so that's something which we definitely would like to know. And there are a couple of questions from the people we'll take later on. So before other colleagues join in, this is something which we all face.
Yeah, thank you, Dr. Raman. I think what work you have done in your institute and with HISI is speaks by itself. But I understand the question. You know the answer. Basically, I think it is important to collect data and keep engaging with them. The investment with communicating this data and facts, because you cannot win over clinicians by emotions, and it is important to keep engaging with them, keep sharing the data, keep sharing the fact, and once they see your honest representation and they see the larger game, we also need to understand their perspective, because a surgeon feels that for him or her, that particular patient is the most important and they would like to sort of save the life. Unfortunately, they feel that antibiotic being the wonder drug is what would save the life. So it is sometimes the peer audits help, sometimes some of the champions help, sometimes they being the champion, the one who is a major defaulter becomes a champion and he changes the behavior. So as I said, there are multiple strategies, and we have failed. Many a times we also have failed because we realize that, like I remember a continuous insulin infusion therapy leading to reduction in surgical site infection. We have failed up till now. So we have not able to convince the endocrinology team and the rest of the critical care team. So there are many places where you do fail, but I think what is important is to just keep engaging, and the patience and the perseverance is the key.
Thank you so much. You said the right word, perseverance. So that is something which, over to other colleagues on the moderating team, please.
Thank you, Dr. Sanjeev. It's a very nice talk, and you did mention that earlier in your talk, different stewardship programs or different like policy and guidelines. You cannot make a unified one because the practice is different. And I can see from the map of Kerala you showed, they have so many like medical colleges, hospital, but even vast majority of them are private hospital. Do you see difference in the practice? And do you like when you want to establish any program for antimicrobial resistance, do you see like like an outcome? Is it unified? The measurement of the outcomes. Do you unify them? And what do you see in the practice of the private hospital? Is that difficult or is it easy to manage?
Thanks, Fahad, for that question. Very difficult question. What we have seen is Kerala is a different country within the country. So it has 99% of literacy. It's a health-seeking behavioral state. The primary and the secondary care is fantastic. So at times it is easy to implement, but I realize out of 35 medical colleges, there are 7 medical colleges which are public and rest are private. This is a state where the public sector gives equal competition in quality to the private sector. They are so good, they are so very well managed and quality driven that that you learn many a times from a good public sector institution. In Kerala, you learn in the private institution. The good point is that they're all sort of governed together by the Ministry of Health and the Director General Health Services, and then the adherence to the guidance which comes from them is easy. The bad point is that even if they don't do nothing, you cannot do anything about for them because it is a permanent job. In the private sector, it is a non-coherent group, and unfortunately they compete. But you could get a good collaborative together just in case, when your whole intention is honest. So what has been done in Kerala is getting all through professional societies. All of them participated for almost 2.5 years, and all medical colleges participated. So there is an ownership from all of them to make the program successful. And there is a phenomenal work which has also been done by WHO India to get the surveillance network. So it's a difficult question and a difficult thing to get people together. It was slightly easy because public participation and private participation was, as a strategy, it did work in the state of Kerala. But we are trying in other states. It is taking time, but I'm sure this is the only way to go.
So before Dr. Heather takes over, just one, this thing will take a question from Zaid Almai on the similar subject, where Zaid wants to know whether, on restriction antimicrobials, until unless the policy is also implemented in the private sector, it would always, it will never achieve the purpose for which, because they're likely to visit, the patient is likely to visit a private practitioner or a pharmacy, especially with OTC, So he wants to know whether you tend to agree with this, or you have some more ideas which have worked in Kerala.
I completely agree. So what we have also done at Kerala is looking at One Health approach. So we had banned colistin as growth promoters in animal husbandry. We have looked at antibiotic consumptions in fisheries. We are geotagging chickens in most of these farms, so it becomes very easy to monitor, though it is unfortunately it's so huge that it is difficult to. In environmental health, there is a lot of work which has been done. All the expired antibiotics, all doctors participate, brings the expired antibiotics and gives it to the IMA green box, so that it is all incinerated and it doesn't get into either a landfill or in water, creating more resistance. So I think it is important that we adopt a comprehensive approach and look at how private group also participate. But the Indian Medical Association and professional societies' participation and getting creating more collaboratives and collecting data and sharing is the only answer to get the private participation in place for antibiotic stewardship.
Thank you, Dr. Sanjeev. So over to Dr. Heather.
Thank you. We really have a lot of interesting questions in the chat. First of all, thank you, Dr. Sanjeev, for a very informative and interesting presentation. It was really well put together, and I'm grateful to be a part of this this group here. I want to build a little bit on what Dr. Fahad had said, kind of taking it a little bit further. As you know, here I'm here with the CDC regional office, so we work with 25 countries directly and indirectly in the region. So it's a really big region. And I'm wondering, you know, what your thoughts are in terms of trying to build a network, a regional network to look at AMR stewardship. Do you think the key considerations that you raised in your presentation would be applicable, you know, looking at issues around training and around the importance of ownership and public-private partnerships, or are there other things that we should be thinking about? Because I know we all learned during this past pandemic, or this current pandemic, however we want to look at it, in light of some of the earlier talks. I know, you know, during the past 2 years, one of the big challenges was really trying to build out and work across countries. And so there are you know, it's really clear that this is not an easy issue to tackle on a country level, but let alone on a regional level. So I'd be interested to hear whether you think that the considerations that you raised in your talk would be applicable on a regional level and in this context. Thank you.
Thanks, Heather. I think a very interesting question. In 2012, when we thought that there is a problem in intensive care and tertiary care hospitals, I thought of reaching out to the government and say that we now need to scale it up and work together so that there is a good rational prescription practices. The first thing which the government asked, is there any data? Why are you bothering when there is no data to say that there is a problem? And when we reached out to 1,000 physicians and did a survey, and we realized that our prescription practices are haywire, and it is extremely bleak. And what we are practicing, many a times we actually don't know the mechanism, and we are still sort of writing, though we consider AMR as a problem. We also reached out to the lab during this survey, and we realized that many of the discs are not available, but they are still testing, they're giving reports, and most of this is manned by microbiology technicians, and there are no microbiologists available. When we reached out to the pharmacist, almost close to 1,000 plus pharmacists, there is no connect between the pharmacy prescription and the feedback which needs to go to the clinicians, and over the prescription, despite of the fact that there is a red line campaign and there is an H1 gadget, there is no adherence to those norms. So all of this has been brought to the notice, and there is a lot of work which is happening at the government level and the private participation. So most of the hospitals now do follow an H1 publication where they take a dual prescription, though there is a lot of work to be done. So what I feel is that first important step is data collection. to understand that there is a problem, and that is what we need to share either with the public sector or with the rest of the private sector. Second important thing is definitely training, because unfortunately in India there is no renewal exams, and post graduation there is nothing which which builds your capacity. What I have also realized is training doesn't change behavior at all. So we need to look at many ethnographic tools where our pattern of infection control practices and prescription practices change. How do we do this? We need to create, as you rightly said, center of excellences and regional centers where people come, see, and actually believe that this is how you need to strategize, and this is what works. And then it is also important, once you create a center of excellence, it is important that institute like where Dr. Raman is there, they need to handhold at least 10 to 12 secondary care hospitals. Because unless the few corporate hospitals improve, it is not going to make any difference. We need to create a ripple effect. And that is where I think we can contribute largely towards an AMR containment program.
Thank you. I mean, what you talk about is becoming a hub and then attaching other hospitals' programs to your own program. So that's a very good idea, in fact, with a hub and spoke situation. So thank you, Dr. Sanjeev. Dr. Fahad, Dr. Heather, you would like to ask something else from Dr. Sanjeev, or because the time is running short. So anything that you want to particularly bring about?
I don't know if you've been following the chat, and quite a few good questions in the chat. I don't know if
yeah.
maybe we can keep those and circle back.
I think we'll pass on to Dr. Sanjeev, and maybe he can keep on answering them. So Dr. Prashant Gowda has asked about monitoring outpatient antibiotic prescription and establishing stewardship based upon that. So all such things, I think you can maybe reply on the chat if Dr. Sanjeev can spend some time.
Sure.
So yeah, with paucity of time, we wind up, and I thank Dr. Sanjeev Singh for an excellent lecture covering everything. You talk about nursing empowerment, which is very, very important, and we have seen the strengthening the AMSP from nursing is something which delivers. And we talked about you touched everything from my point of view that needs to be done and implemented firsthand. So thank you, Dr. Heather and Dr. Fahad, for being very understanding and precise questions, and bringing about the tough things from Dr. Sanjeev to answer upon. Thank you, everyone. Thank you, the audience, for great interactions. And once again, have wonderful times. So from all of us, on the moderation group for this first lecture, over to Dr. Mayer, please.
Thank you so much for that absolutely fabulous talk, which covered so many aspects. It's really mind-boggling, and you touched on all of them, and you've done all of them. So you really walked the talk. And Kerala, I love what you said. Kerala is a country within a country. And that is really very, very true. And to many more successes to you. And I hope we handhold all the other hospitals, as you said, and we bring in some change. Thank you so much, Dr. Sanjeev. Thank you, Dr. Raman, Dr. Heather, Dr. Fahad, for that excellent session. Thank you so much.